I'll talk a little bit about my career background and then move into some research that I've been working on to hopefully make the case that hypertension is not inevitable. And I'm particularly excited to be here this first Monday of February, which among other observances is American Heart Month. And just a quick plug, Friday, February 7th is National Wear Red Day. The Office of Research is organizing a group photo. So please wear red if you'll be on campus Friday and meet at noon. So hope to see some of you there. All right, so as Dr. Stress has already alluded to, my career journey has indeed been a journey. So kind of going back to the beginning, I am originally from a town called Chappaqua, New York. This is about an hour from New York City. My high school is named for Horace Greeley, who was a newspaper editor and ran for president against Ulysses Grant. He did not win, but nonetheless, a big figure in our town. That was at least until the Clintons moved to Chappaqua. So we've had numerous encounters with the presidency in Chappaqua. So I grew up in New York, and my dad's side of the family is from New York. My mom is from Birmingham originally, and most of my mom's side of the family went to Auburn. So that's also where I went to college. So as you can see on the slide, I was a chemistry major, also a minor in French. I just started doing Duolingo again. If anybody would like to be friends on there, feel free to look me up. But as an undergrad, I had the opportunity to do research in a chemistry lab. And I would say that was a really valuable learning experience, but among the things I learned were that I did not want to work in a chemistry lab. I also wanted to do research that I felt like I could see more direct applications to the problems that we were trying to solve. And I thought I wanted to be more in a health-related field. I knew, though, that I wasn't that interested in direct patient care. So I was trying to figure out, okay, what is the career path for me? And I knew I was interested in health at a population level and keeping people out of the doctor's office, except for preventive services. So eventually the words public health and epidemiology came on my radar. And so that led me to apply to MPH programs and took me to the Yale School of Public Health. So there I did my MPH in chronic disease epidemiology and thought pretty early on that I probably wanted to do a PhD at some point. But being new to public health, having gone right through school up to that point, thought it would be useful to get a little bit of work experience, gain some perspective on the field, kind of hone my interest for a PhD program. So I applied to a number of different positions, one being a fellowship that was co-funded by the CDC and the Association of Schools and Programs in Public Health, the ASPPH. So that fellowship program placed me with a mentor at CDC. I was placed in the Division of Adolescent and School Health. There I was specifically on the Youth Risk Behavior Surveillance team. And so we worked on the youth risk behavior surveillance system, among other things, which I think has gotten a lot more attention in the last 3 or 4 days than it may have otherwise. Unfortunately, the data were taken down from the website on Friday, but I'm hopeful to see those restored, as I think it's a really valuable resource. And being right out of my MPH, working on a surveillance system was really a great opportunity to see how these data were collected, what it took to run a surveillance system. And my mentor knew that I was interested in a PhD program. So she gave me some opportunities to write papers based on our data. But she also gave me an opportunity to interview our grantees and learn how they used our data to inform school health policies and programs. So it was really nice to kind of see how that all came full circle. So my fellowship program was for 1 to 2 years. We decided pretty early on to extend it for the second year. And then a full-time, for a permanent position opened on my team. So my mentor asked if I was interested, and I felt like I was still learning, being challenged, growing. So I decided to apply for the position, put off going back to school a little bit longer. So I ended up being in the division for about 3 years. And then a detail opportunity was posted. A detail in government speak is a rotation to another part of the agency. These are generally intended as temporary assignments to work on a particular project. So this detail opportunity was to work in the office of the CDC director as a special assistant. And my division deputy director heard about the posting. She talked to my mentor. They eventually came to me and said, you're eligible. We think you should apply. And I was like, oh yeah, sure, I'll apply. I'm definitely not going to get it, but send in my resume. Let's do it. And fast forward, I did get the position. I'd been warned it would be pretty fast paced, and it's 120 days. I can do anything for 120 days. But as you can see on the slide, 120 days turned into another 5 years. So I put off going back to school for a lot longer, but no regrets. It was an amazing opportunity. The CDC director at the time was Tom Frieden, who had formerly been the health commissioner in New York City under Mike Bloomberg. So they banned smoking in restaurants and bars, got the trans fat out of foods, policies that were later adopted much more widely. So really at the forefront of chronic disease prevention, the use of epidemiology to inform policy. So in my day-to-day, though, I was responsible for briefing materials, staffing the director at meetings and events. Also had the opportunity to work with programs across CDC to advance agency priorities, visited more than 20 state and local health departments with the director to learn about CDC's funded programs. My last couple of years, I also worked on the Ebola response in West Africa, based from Atlanta, as well as the Zika virus epidemic. So actually, before I get to that, I did want to just take a brief aside to talk about the reason I stayed for 5 years in that position. We were working on an initiative called Million Hearts. So this was co-led by CDC and the Centers for Medicare and Medicaid Services, the CMS. And the goal of this initiative was to prevent 1 million heart attacks and strokes in 5 years. So up until that point, my focus really had not been on cardiovascular epidemiology. But we aim to accomplish this goal through both improving community-wide prevention to reduce tobacco use, eliminate the use of artificial trans fats, and reduce sodium intake, and improve clinical care of what we call the ABCs, or appropriate aspirin use, blood pressure control, cholesterol management, and smoking cessation. So this initiative was getting ready to launch while I was in my detail, and then I stuck around to kind of see it through. And while this was a really exciting opportunity, really changed the course of my career towards a focus on cardiovascular disease and blood pressure in particular, the initiative did not achieve its intended goal. So only 135,000 events out of the million that we estimated, based on modeling studies and thought we could accomplish in 5 years were prevented. And I share this just to say that I think in our careers, a lot of things are not going to go the way you planned. I think that's normal, but there were a lot of lessons learned for this. A number of the policy initiatives that were part of Million Hearts were either delayed or not implemented. So I could give another talk on sort of reasons why I think this happened, but nonetheless, it really changed the course of my career, and I think has motivated a lot of the work that I do. And this is why, if you've taken my class or you will take my class, I'm kind of obsessed with blood pressure, because I think it's something that we can and should improve prevention and control of hypertension in this country. So anyways, a little bit of an aside into Million Hearts, but in 2016, I did go back for a PhD, as Dr. Shrestha mentioned, at Johns Hopkins. So there I focused on cardiovascular disease epidemiology. I finished my PhD in March of 2020, right as COVID was taking off. So honestly, I just decided to stay put and do my postdoc there. I really hadn't planned on going into an academic career, but my postdoc mentor, I say, eventually kind of brought me around to the idea and introduced me to some folks here at UAB. So we started collaborating, and then I eventually made my way here in 2022 in September as an assistant professor. So my work currently focuses on the prevention and control of hypertension. I do some work in observational studies, mostly longitudinal cohorts, as well as using national surveillance data like NHANES. I also work on several intervention studies. A lot of my work is based in the US, but I've also gotten into some global cardiovascular disease projects. So I'm happy to talk to students about any or all of that, or careers. So please feel free to get in touch if anything I've said here resonated with you. All right, so now let's switch gears to kind of talking more about the scientific portion of this program. And so again, our focus today is on the idea that hypertension is not inevitable. So as background, though, we know in most industrialized societies, including the US, systolic blood pressure increases with age. And while hypertension is not inevitable, the lifetime risk is very high. So the lifetime risk of hypertension is over 80% among both white and Black men and Black women, around 70% among white women. And while it is extremely common, this does not represent normal aging. So I want to make that clear. Just because it happens a lot doesn't mean it should happen a lot. There's evidence from certain non-industrialized populations that there's no age-related increase in systolic blood pressure. So some of the earliest studies that I'm aware of came from the Intersalt. Another study done more recently by Noel Mueller, who was someone I knew at Johns Hopkins, also illustrates this concept. So these two scatter plots that you see are from Amerindian communities in the Venezuelan rainforest. They are inaccessible by land. The community on the left, the Yaquana, there's an airstrip there, so they are sometimes visited by Western folks. They have some access to medication, some other foods. The Yanomami, in contrast, are some of the most isolated populations in the world. They are a hunter-gatherer-gardener community. And what you see among the Yanomami on the right there is that essentially the slope of blood pressure with age is flat. So this is just cross-sectional data. These are not longitudinal as people age, but you can see there's no age-related increase in systolic blood pressure. And the Yaquana on the left, again, who have a little bit more exposure to Western lifestyles, you can see that there's not a large increase in systolic blood pressure with age, but there is that age-related increase that we're talking about. And you can see that this increase may start at very young ages when it does occur. So do I think we need to go back to being hunter-gatherer in order to maintain normal blood pressure? No, I think it's a lot harder to do that in our current society, the way that we're structured and the influence that has on our lifestyle. But even in the US, there are individuals who maintain normal blood pressure and experience very little age-related rise in blood pressure over the life course. And so why should we bother focusing on preventing hypertension and maintaining normal blood pressure when we could just treat hypertension? We have very good medications. Well, there's evidence showing that cardiovascular disease risk starts at blood pressures in the normal range. So this histogram comes from the multi-ethnic study of atherosclerosis, or the MESA cohort. And this included people with systolic blood pressures between 90 and 129, so they don't have hypertension. They were also free from all other cardiovascular comorbidities, not on any type of medications. And what you see is a direct relationship between systolic blood pressure and the risk of incident cardiovascular disease. They estimated for every 10 millimeter of mercury increase in systolic blood pressure, there was a 53% higher risk for cardiovascular disease. And additionally, we know that the treatment of hypertension, while very effective at reducing the risk of cardiovascular disease and mortality, does not fully reduce or restore your risk to the level of somebody with the same blood pressure who does not need antihypertensive medication. So the fact that you need medication in the first place is an indicator of increased risk. And intuitively, if we look at this schematic, this is from a paper in The Lancet, ideally what we want across the life course, as shown on the x-axis, is to kind of maintain a healthy blood pressure. This figure, the line in green shows the ideal life course. On the y-axis, you can see sort of a healthy blood pressure, elevated blood pressure, subclinical organ damage, and then overt cardiovascular disease, loss of quality of life. So ideally what we want is this green line, maintaining a healthy blood pressure over the full life course. Most people will experience this average life course shown in blue, where they will develop hypertension, may go on to develop cardiovascular disease. Some people will follow this red line of early vascular aging. And these arrows on the figure represent opportunities for intervention. So if we intervene earlier in life, right, we have the opportunity to shift that trajectory more towards the ideal life course. So this is our primary prevention. So there are much greater benefits as compared to later intervention, secondary or tertiary, where you may prevent or delay cardiovascular disease, but not as effectively as with early intervention. I would also argue that a focus on preventing hypertension and maintaining normal blood pressure is important for health equity. We know in the US there are differences in blood pressure between Black and white individuals that occur as early as adolescence, and that hypertension on average develops earlier among Black individuals as compared to their white counterparts. So the prevalence of hypertension is higher, and among those with hypertension, control of blood pressure is lower in Black as compared to white adults. And these differences in blood pressure and related health outcomes are not biological and can and should be avoided. So with this as a backdrop, this has launched several different research studies that I've been involved in. So the first one that I'll talk about looked at what proportion of US adults have normal blood pressure by age. The second study looked at who maintains normal blood pressure from middle into older age. The third project asked, what is the projected impact of maintaining normal blood pressure or preventing hypertension on life expectancy and healthy life expectancy? And finally, can we prevent hypertension and maintain normal blood pressure? And for students in the audience, this first question, what proportion of adults have normal blood pressure, is a cross-sectional study. The second question on who maintains normal blood pressure, this is going to be a longitudinal study, a cohort study that I'll share. The third bullet is a modeling study. And then finally, the fourth one on can we prevent hypertension, we'll look at a series of randomized controlled trials. We'll hit all the different study designs as we go. So starting with this first project on what proportion of US adults have normal blood pressure by age. So these data are from the National Health and Nutrition Examination Survey from 2011 to 2018. And this figure shows the age-specific prevalence of normal blood pressure. Normal blood pressure is defined as having blood pressure below 120/80. So the proportion with normal blood pressure are shown in the green. And you can see that it steadily decreases with age. Around 57.8% of adults 18 to 45 have normal blood pressure, compared to 11.2% of those 65 to 75 and 5% of those 75 to 80. So it's uncommon, but there is a small proportion of older adults who have normal blood pressure. In this study, we also looked at factors associated with having normal blood pressure. And just for the sake of time, I'll focus primarily on the older age group here. And we found that in those ages 65 and older, age was inversely related to the prevalence of normal blood pressure, as expected. We found that Black and Hispanic adults had a much lower prevalence of normal blood pressure compared to non-Hispanic white adults. Meanwhile, consuming alcohol only in moderation or not at all compared to heavy drinking was associated with a higher prevalence of normal blood pressure. Those who met the physical activity recommendations compared to those who did not, as well as those who were overweight or had normal BMI compared to those with obesity, and those with a higher DASH diet score compared to lower, were more likely to have normal blood pressure. So this, again, was a cross-sectional study, but I think these findings from a hypothesis generating, and we were able to look at these in a longitudinal cohort that I'll show you next. So next, looking at who maintains normal blood pressure into older age. So as I mentioned, this is data from a cohort study, specifically the Atherosclerosis Risk in Community Study, or ERIC. So ERIC began in 1987 to 1989. It enrolled over 15,000 adults who were middle-aged at the time, ages 45 to 64, from 4 different US communities, and they've been followed now for over 35 years. The cohort is ongoing. So the objectives of this particular study were to estimate the proportion of ERIC participants who maintained normal blood pressure from the baseline in 1987 to 1989 through 1996 to 1998 and 2011 to 2013, which were when the 4th and 5th examination visits took place. We also aimed to estimate the risk of cardiovascular disease, dementia, and poor physical functioning after visit 5 associated with maintaining normal blood pressure. And then finally, in exploratory analyses, we again looked at participant characteristics associated with maintaining normal blood pressure. So here is a timeline of the ERIC study visits, and I'll show how our study relates to this in a moment. So as I mentioned, the first ERIC visit took place in 1987 to 1989 when participants were 45 to 64 years of age. The first 4 ERIC study visits occurred about 3 years apart. So visit 4 took place in 1996 to 1998 when participants had ages ranging from 52 to 75. There was subsequently a gap in study visits. ERIC was sort of reimagined as an aging cohort looking at cognitive outcomes, and a new visit, visit 5, occurred in 2011 to 2013 when participants were then 71 to 90 years of age. And participants, as I mentioned, are still being followed given the interest in cognition. They are now being followed much more frequently given the age of the cohort. And so in our study, we were specifically interested in adults who had normal blood pressure at the baseline study visit. And we required that they attended visit 5. So between visit 1 and visit 5, we assessed their blood pressure, patterns of blood pressure. And then after visit 5, we assessed physical performance, as well as incident cardiovascular disease and dementia, which at the time of this paper had been adjudicated through the end of 2020. So this is our outcomes assessment period. And then we looked at the maintenance of normal blood pressure in 3 different categories. So again, we only included those with normal blood pressure at baseline. So the first category included those who did not maintain normal blood pressure through visit 4. So you can think of that as not maintaining normal blood pressure through middle age. The next category was those who maintained normal blood pressure through visit 4, but not visit 5. So they didn't make it through that large gap that I showed you before. So these people maintained through middle age, but not older age. And then the final category was those who maintained normal blood pressure through visit 5, so into and through older age. As mentioned, outcomes of interest included cardiovascular disease, dementia, and poor physical functioning. The participant characteristics that we looked at included several demographic factors, several different health behaviors. Some of the health behaviors we had multiple measurements of, so we were able to look at changes between the baseline and visit 5. And then we also looked at different psychosocial factors. These were measured at the second ERIC visit. They were not measured at the first, but for the purposes of this analysis, the measurements in visit 2 were considered their baseline measurements of psychosocial factors. So in the analysis, what we first did was to calculate the percentage of participants in each of those 3 blood pressure categories. We then estimated hazard ratios for incident cardiovascular disease, dementia, and poor physical functioning, and examined associations of participant characteristics with maintaining normal blood pressure. So here is our study flow diagram. So we started with all ERIC participants who attended the baseline visit. We excluded those without normal blood pressure at baseline. That was the largest exclusion in the first box. So about 60% of participants did not have normal blood pressure at the baseline. Among the 6,414 who did have normal blood pressure at baseline, we excluded those who did not attend visit 5, again, because we're interested in the maintenance of normal blood pressure during that time period. And then among those who attended visit 5, we excluded those with missing information on participant characteristics of interest, leaving us with a study population of 2,699 individuals. So here again is kind of the description of the ERIC study visits. This is our blood pressure assessment period between visit 1 and visit 5. At baseline, participants in our study had a mean age of 50.3 years. At visit 4, they had a mean age of 60.2 years, and at visit 5, they were nearly 75 years of age on average. And then with respect to our blood pressure maintenance categories, what we found was that 52.4% of participants did not maintain normal blood pressure through visit 4. 32.6% maintained normal blood pressure through visit 4, but not through visit 5. And then finally, 15% of participants maintained normal blood pressure all the way through visit 5. And then with respect to the outcomes of interest, so these are the hazard ratios. What you see for cardiovascular disease is sort of a stepwise reduction in the risk of incident cardiovascular disease with maintaining normal blood pressure through visit 4 and visit 5. For dementia, we did not have significant findings here. We hypothesized, because we restricted the study population to those with normal blood pressure in midlife, that we may have missed sort of a critical window. We know that high blood pressure in midlife is associated with dementia later in life. And then for poor physical function, again, we sort of see this stepwise reduction in risk associated with maintaining normal blood pressure through visit 4 and through visit 5. And just to point out some things about the blood pressures, the blood pressure levels in each of these 3 groups. So those who maintained normal blood pressure through visit 5 had the lowest mean systolic blood pressure at baseline. So it was around 100. At visit 5 in this group, their mean systolic blood pressure was 110. So they experienced roughly a 4 millimeter of mercury increase in systolic blood pressure per decade, as compared to what we typically see in the US, which is around 7 to 15 millimeters of mercury per decade. So not as flat as that curve I showed you earlier in the Yanomami population, but a much less steep increase as compared to what we typically observe. And then with respect to baseline characteristics that were associated with maintaining normal blood pressure all the way through visit 5, similar to the NHANES analysis, age was inversely associated with maintaining normal blood pressure. Again, Black adults had a much lower likelihood of maintaining normal blood pressure compared to white adults. This is even among those with normal blood pressure at the baseline study visit. And also sort of concurrent with the NHANES analysis, those who had normal BMI at baseline were nearly 1.5 times more likely to maintain normal blood pressure. So as I mentioned, we also looked at changes in some of the health risk behaviors between visits 1 and visit 5 to understand their associations with maintaining normal blood pressure. The only health behavior for which there were significant findings were with respect to obesity. So compared to those with obesity at the baseline and at visit 5, those who were overweight at visit 1 and then subsequently had normal BMI or overweight at visit 5 were more likely to maintain normal blood pressure. And those with normal BMI at both of those time points, they were nearly 2 times more likely to maintain normal blood pressure through visit 5. So to summarize this ERIC analysis, among participants 45 to 64 years of age at baseline who had normal blood pressure, 15% maintained normal blood pressure over a time period of 23.5 years, at which time participants were nearly 75 years of age. Maintaining normal blood pressure was associated with lower risk of cardiovascular disease and poor physical function. And having normal BMI at visit 1 and at both visits 1 and 5 were associated with maintaining normal blood pressure into older age. So the takeaway here, although not the most common trajectory, maintaining normal blood pressure over the life course is feasible, and maintaining normal blood pressure into older age was associated with lower risk of health outcomes important to older adults. All right, so moving into the next study that I'll highlight. So again, this one was on the projected impact of maintaining normal blood pressure or preventing hypertension. And specifically, we aim to estimate the effect of preventing hypertension and maintaining normal blood pressure over a lifetime on overall life expectancy and healthy life expectancy in Black adults. So before jumping into this study, I first want to spend a minute on the concept of healthy life expectancy. So this represents the number of years that a population can anticipate living in good health, estimated by adjusting total life expectancy for years lived in less than ideal health. And as a visual example, let's say I have person A and person B, their lifespans are shown here in the horizontal bars. You can see that at younger ages, both participant A and participant B spend a number of years in ideal health. As they age, they incur these incidents of disease or disability, and in the years preceding death, they spend several years living with disease-related disability. And so person A lives a total of 65 years, person B lives a total of 63 years, and let's say I told you that person A lived 52 of their 65 years in good health, whereas person B spends 63 of their 73 years in good health. So person B lives 8 years longer than person A. They also spend, though, 11 more years in good health. So person B both lives longer and lives more years in good health. And if we think about this from a public health standpoint, right, our goal is not only to maximize life expectancy, but to maximize healthy life. So healthy life expectancy is used as a summary population health metric by a number of different governments and public health organizations. So in this study, we draw on data from the Jackson Heart Study. The Jackson Heart Study is a community-based sample of self-identified Black adults who reside in the Jackson, Mississippi area. They were enrolled between 2000 and 2004, and at baseline, there were 5,306 participants. For this analysis, I mentioned this was a modeling project. So we used the blood pressure control cardiovascular disease policy model, which is a discrete event simulation of blood pressure related interventions on the left that then projects long-term health outcomes as shown on the right. Some of the outcomes that the model has been used to project include cardiovascular disease events, survival, and healthy life expectancy, which were all of interest to us in this particular study. And this slide, I'm not sure how much detail folks want about the model, but I'll try to give you just a brief overview of sort of how it works. The first step is model calibration. So the model is calibrated to match age and sex-specific cardiovascular event rates and CVD and all-cause mortality, first for all non-Hispanic Black adults in the US, and then specifically for this analysis of Jackson Heart Study participants. What we do next is to impute lifetime cardiovascular disease risk factor trajectories from age 20 to 100 using data from Black participants in the NHLBI pooled cohort studies. So the pooled cohort studies include the Jackson Heart Study as well as ERIC, which I just talked about, Cardia, MESA, and several other cohorts. And here are the cardiovascular disease risk factors that are imputed. And based on these risk factor trajectories, what we do is to estimate the risk of cardiovascular disease events. So these two steps essentially tell us the status quo scenario. So this is what's happening in the absence of any intervention based on these projected risk factor trajectories. And then what we do is to apply our interventions that alter an individual's cardiovascular risk factor trajectories, in this case, specifically blood pressure. And then we project the resulting effects on life expectancy, healthy life expectancy, and cardiovascular disease. And the benefits of lowering blood pressure specifically come from a meta-analysis that provided a relative risk reduction estimate associated with a 10 millimeter reduction in systolic blood pressure. So this is our intervention step of the model. So in this analysis, we use a simulated population, and the way we get there is to first start with Jackson Heart Study participants who meet our inclusion criteria. So we required that Jackson Heart Study participants have at least one observed value for the cardiovascular risk factors that are part of the model, and that they have available blood pressure measurements at the study baseline. So this left us with a cohort of 4,933 individuals. And then we create our simulated cohort. So what we do is to randomly sample Jackson Heart Study participants who meet our inclusion criteria and then use their imputed cardiovascular risk factor trajectories. So as I mentioned, we have these imputed blood pressure trajectories that represent the status quo. So in this particular case, we're looking at the status quo of blood pressure management in Jackson Heart Study participants. So without any intervention, so we just let their blood pressures go. They may be treated. So we're just kind of simulating normal care processes. And then in our two intervention scenarios, we modeled one, which looked at preventing hypertension. So in that intervention, we're requiring blood pressure to remain below 130/80 from age 20 to 100 or death. And then we also looked at an intervention to maintain normal blood pressure over the life course. So in that one, we require blood pressure to remain below 120/80, again, from age 20 to 100 or death. Our outcomes were life expectancy and healthy life expectancy at age 20. We used at age 20 just to align with some other papers in the literature. And healthy life expectancy, again, is estimated by adjusting remaining life years for years lived in less than ideal health. There are a couple of different ways healthy life expectancy is calculated in the literature. Some adjust for disability, some adjust for quality of life. We adjusted for health-related quality of life in this particular analysis. And then as a secondary outcome, we were interested in cardiovascular disease events. So again, we estimated the overall life expectancy and healthy life expectancy at age 20. We estimated cardiovascular disease events avoided by preventing hypertension and maintaining normal blood pressure. And we also estimated the distribution of ages at which projected cardiovascular disease events would occur in the age grouping shown here. So as I mentioned in our primary analysis, we're assuming that preventing hypertension and maintaining normal blood pressure reduce the risk of cardiovascular disease events, applying that relative risk reduction from the meta-analysis I mentioned. And we're assuming that the gains in life expectancy and healthy life expectancy come from the avoidance of cardiovascular disease events. And that's the only way in which life expectancy and healthy life expectancy can be gained. We know, though, that adults without hypertension are healthier on average than their counterparts with hypertension, and they have lower CVD and mortality risk than would be expected by lower blood pressure alone. So in a secondary analysis, we assumed that preventing hypertension and maintaining normal blood pressure directly reduce the risk of both cardiovascular disease and mortality. And we did this by using an additional calibration factor to replicate cardiovascular event and all-cause mortality rates in those participants without hypertension at baseline. So this was a lot of setup. Now we're going to move into the results of the modeling analysis. So here first are the blood pressure trajectories. So shown in blue are the imputed trajectories. So again, these are without any intervention. In red, we have the scenario in which we prevent hypertension, and in orange, we have the scenario where we maintain normal blood pressure. And then here are the results for life expectancy and healthy life expectancy. So starting with our imputed blood pressure trajectories, again, the status quo, the total length of the bar represents total life expectancy. So this dark blue plus the lighter blue shade together represent total life expectancy at age 20. In this case is 80.8 years. The part in the darker portion of the blue bar represents healthy life expectancy at age 20. In this case is 70.5 years. So then in my primary analysis, if we prevent hypertension over the life course, we project that life expectancy at age 20 would increase by 1 year, while healthy life expectancy would increase by nearly 3 years. In the scenario in which we maintain normal blood pressure, life expectancy is projected to at age 20 is projected to increase to 82 years. And again, we see nearly a 3-year increase in healthy life expectancy. So our takeaway here at age 20, life expectancy is projected to increase by 1 year. Healthy life expectancy is projected to increase by 3 years. So in the secondary analysis, again, here we're allowing the reduction in blood pressure to impact both cardiovascular disease and mortality. Starting with the same status quo, what we see is that if we prevent hypertension over a life course, in this case, we gain around 4.5 years of overall life expectancy and just shy of 6 years of healthy life expectancy. For maintaining normal blood pressure, kind of a similar story, gain around 4.5 years of overall life expectancy and nearly 6 years of healthy life expectancy. So to summarize, again, at age 20, life expectancy increased by around 4.5 years, healthy life expectancy increased by about 6 years. And here are projected survival curves and cardiovascular disease events by age group. So starting with the top left, these are the survival curves for the primary analysis. You can see at older ages, although I'm not sure how well you can see here, there's a little bit of separation between the blue and the red and the orange lines. So there's survival is poorer in those in the imputed blood pressure trajectory scenario. We didn't see a lot of separation between the preventing hypertension and maintaining normal blood pressure scenarios, which I think is a function of how we modeled it, which I'm happy to get into more in the Q&A. But then below that in panel C and looking at the cardiovascular disease events avoided, what we see is that there's a modest number of events avoided before age 65. Most of the events that are avoided occur between ages 65 to 84. And then we also see sort of a modest number of events avoided after age 85. In the top right, looking at the secondary analysis, again, allowing for those direct effects on both mortality and cardiovascular disease, we see earlier separation of those survival curves and a more pronounced separation between the blue and the red and orange lines. And as compared to the primary analysis, a larger number of events would be avoided before age 65. A larger number of events would also be avoided between ages 65 to 84, while a smaller number of events are avoided as compared to the primary analysis at ages 85 and older. And this may be because as people are living longer, we're delaying events to later ages. So in summary, preventing hypertension and maintaining normal blood pressure are projected to increase life expectancy in Black adults by approximately 1 year and increase healthy life expectancy by nearly 3 years. When allowing for direct effects on both cardiovascular disease and mortality, preventing hypertension and maintaining normal blood pressure are projected to increase life expectancy by more than 4.5 years and healthy life expectancy by nearly 6 years. And I didn't go into these results for the sake of time today, but we found that these interventions may also be equity promoting. We looked at the results stratified by level of education and household income. And while all groups had gains in life expectancy and healthy life expectancy, those with lower levels of education and income gained more as compared to their higher income and those with higher levels of education. I think there's also reason to believe that Black adults may gain more in terms of healthy life expectancy and life expectancy compared to white adults, and may narrow those gaps that we know exist in the US with respect to life expectancy and healthy life expectancy. So now moving to our sort of last research question is, can we actually do this? How do we prevent hypertension and maintain normal blood pressure? And the modeling study that I showed you, we're sort of agnostic to how we do it. We're just saying, if we could theoretically reach blood pressures of this level and maintain them over the life course, this is what would happen. The much bigger challenge is, how do we actually achieve that? And while some of the factors associated with normal blood pressure that I've showed you in this analysis were sort of lifestyle behaviors, we know that these happen in the context of the social and structural determinants of cardiovascular health. I really like this conceptual framework from Tiffany Powell-Wiley and colleagues, that nicely illustrates how the structural determinants of health and health equity influence social determinants of health more downstream, which ultimately influence health behaviors and the manifestation of hypertension and future cardiovascular disease. So one project that I'm involved in that sort of seeks to start addressing both lifestyle behaviors and the social determinants of health that contribute to hypertension is called the RESTORE Network. So RESTORE comes from addressing social determinants of health to prevent hypertension. This was the first ever American Heart Association funded health equity research network, and it specifically focuses on the prevention of hypertension. So you can see some of the other institutions which are involved. The RESTORE Network specifically aims to partner with Black communities to mitigate the impact of social determinants of health on blood pressure, and to develop and evaluate strategies to implement evidence-based lifestyle interventions to lower blood pressure, and to disseminate findings to policymakers and stakeholders, which I think this is the part where we start to push more upstream and make these interventions sort of more of the healthy default or the context in which people can adopt healthier behaviors. And then there is also an emphasis on training of early career scientists. So the RESTORE Network includes 5 independent randomized controlled trials, which are all testing different approaches to preventing hypertension. So one study based at NYU called CLIP is a community, they recruit Black men in barbershops in Staten Island, and they use a sort of community health worker intervention to link people to care and address social determinants of health. The Epiphany study, which is based in the School of Medicine here at UAB, led by Andrea Charrington, partners with Black churches in the Black Belt region of Alabama and works with community health workers. And there's also a church-based intervention component focused on nutrition and physical activity. The LEAP hypertension study at Wayne State in Detroit uses a mobile van, and they've hotspotted different zip codes around the city of Detroit where people are likely to have elevated blood pressures, poor access to care, higher social needs. The linked BP study at Johns Hopkins uses a home blood pressure telemonitoring approach with community health worker support. And finally, the Go Fresh study is testing the effects of DASH diet groceries on Black residents in food areas identified as food deserts in the Boston, Massachusetts area. Each of these trials is also supported by the Restore Network structure, and we have a number of cores that are part of this project. So we have a blood pressure measurement core to train and standardize blood pressure measurements in each of the 5 studies, a training core to work with early stage investigators, a community engagement core, which has been really integral to this type of work, an intervention core to support the development and delivery of each of the 5 interventions, and finally the statistical core, which I happen to lead and is based here at UAB in the Department of Epidemiology. So happy to talk more about this project with folks who are interested. So these cores sort of provide common support to the network. And while these are all different intervention studies, there are a number of synergies across the 5. So the eligibility criteria for each includes Black adults with elevated blood pressure or stage 1 hypertension who are not eligible for medications. We're trying to prevent hypertension. The primary outcome is change in systolic blood pressure at 12 months, except for one study that looks at it at 3 months. We went through a process at the beginning of the study to harmonize data elements in our questionnaires across the 5 studies. So we have a number of different measures with a heavy emphasis on social determinants of health. And then each of the studies is also looking at implementation outcomes. So these are hybrid effectiveness implementation trials using the REAIM framework. All 5 studies are also conducting costing analyses, and they're doing this in real time to hopefully make the case that these are cost effective and increase interest and adoption perhaps among payers. And as I mentioned before, the community engagement has been a big part of this study, and each of the 5 trials has a major emphasis on this. I just wanted to give a shout out to the Epiphany team at UAB. I think I saw Friday earlier, who I know worked with them over the summer, but they invited my team from the statistical core to attend some of their recruitment events. And I think it's good to get out from behind the computer and into communities and see how the recruitment works and to meet the people who are participating in the studies. So this work is ongoing, so I don't have results to show you yet. 3 of the 5 studies are done with recruitment. And as I mentioned, the primary outcome is at 12 months. The earliest study to complete will have their primary outcome data in the middle of March. So much more to come from the Restore Network. And to date, though, we've learned a lot of lessons around recruitment, how to engage people in a prevention study. They don't have a health condition. You're asking them to do something for a disease they don't yet have. So I think that's been really interesting, and also engaging communities in this work. Retention similarly, how do we keep people engaged in this type of study once we've enrolled them? Again, the common data elements will enable pooled analyses and comparisons across the sites, which I think will be really interesting. And as I mentioned, I think we'll be uniquely positioned to characterize social determinants of health. We have measures that are not collected in other studies like NHANES or the BRFIS, for example. And finally, as hopefully I've emphasized here, engaging communities is key to advancing the science around health equity and hypertension prevention. All right, so kind of bringing it home here. So to summarize across all of these studies now that I've shown you, here are some of the key takeaways. So the percentage of US adults who have normal blood pressure decreases with age, but there are older adults who have normal blood pressure. Maintaining normal blood pressure from middle into older age, so it's important to continue to maintain it over the life course, is associated with lower risk of cardiovascular disease and poor physical functioning. We've seen in a couple of our studies that having and maintaining a normal BMI may be important for maintaining normal blood pressure. We've shown that preventing hypertension and maintaining normal blood pressure over the life course could increase life expectancy and healthy life expectancy among Black adults. And implementation research, like from the Restore Network, is needed to understand how to prevent hypertension in communities and promote health equity. And I think even beyond what we're doing in Restore, which I think is great, I think there's still a need to move further upstream to address the structural and social determinants of health that contribute to the development of hypertension. So that's all I have. I really want to thank all of my study co-authors from the work that I've shown you, the study staff and participants from each of these different projects, and a special shout out to the Restore Network and the Statistical Core members who I've listed here.